This is our last lecture for Rad Sci 1. We're talking about artifacts this week. Your quiz will be 10 questions, multiple choice. You'll take it the same day as your grids quiz. I'll post both passwords at the same time so that you'll have access to them and you can just take them sequentially. They'll count for 2 separate grades. So we've talked about artifacts in the past, so we know that they're visual features on a medical image that either simulates or obscures tissues and makes the overall image quality worse, and especially the diagnostic quality. So if I'm reading an image or another radiologist is reading an image, it can really obscure things or make us think that there's a pathology when there's not. In specifically digital radiography, when we're using DR machines, there are 3 specific types of artifacts that we can come across. Those related to the image receptor, those related to software, and those related to objects. As far as imaging receptor artifacts, there's a reason why that IR board is so expensive. Any rough handling, scratches, or dust that's stuck on those IRs can lead to artifacts. If you drop it, rough handling it, you can cause pixel failure, so that can occur requiring replacement of the entire IR board. If you are using a CR machine, then like down in the practice lab, those are the cassettes that need to be fed in to a machine that takes the image, puts it onto the computer, but also erases the image when you're done looking at it. So if that CR machine does not erase the previous exposure, you can get what's called a ghost artifact. So here you can see a nice chest image, but if you look closely enough, you also see a pelvis that's kind of upside down. So pelvis here on either side, the pelvic wings coming up this way. So at first glance, you're kind of looking at this side of the chest like, what is this weird radiopacity? But you can see that it is like that ghost artifact of a pelvis spookily superimposed over that chest. Here's some more examples of scratches due to rough handling of the IR. On the left, they look a little bit more like scratches. They're typically radiopaque. On the right, I would have to differential this versus other conditions because this looks like it could be a calcification in the soft tissue or maybe a sliver of bone that fractured off somewhere. Maybe they had trauma and their soft tissue ossified. So there's a lot of different things that this could look like. Even a foreign body, maybe they scraped their elbow outside and got metal kind of shoved within their soft tissues there. So there's a bunch of different things this could be, but it turned out to just be a scratch on the IR. So things like that can occur and cause radiologists to think one pathology when it's just an artifact. We can also have software artifacts. So once those digital images are taken and the computer's processing them, they're taken in as raw data, and that raw data needs to be processed. The processing is required, necessary for diagnostic visualization to occur, for an actual image to be created. So pre-processing is a process where there's corrections for potential artifacts. So if the machine thinks that there's dead pixels or dead rows, there's a way to kind of fix that. So interpolation is the process of assigning a value to a dead pixel based on other recorded values of pixels. So it kind of takes all the pixels in that surrounding area and says, okay, this one's supposed to be radiolucent, so it's radiolucent. I'm sure you can think of some issues that could occur there. What if that pixel wasn't radiolucent? What would happen then? Flat fielding also is a pre-processing correction to kind of equalize the response of each pixel to a uniform X-ray beam. So it kind of averages out pixels and makes it so that there aren't areas where there should be certain levels of contrast showing up as different levels of contrast. So it kind of overall equalizes that response. As far as CR image receptors, like the ones in the practice lab, the cassettes, they're much more sensitive to background radiation and scatter and need to be re-erased before being used there so that you don't get those ghost artifacts. For digital imaging as well, we have to also think about how these images are going to be stored in the computer. So If you've ever taken images before or taken pictures and uploaded them to your computer, you know that sometimes the file sizes can be really large, especially if they're video files. So there's different ways to compress these files to make it so that they take up less space. Therefore, you can store more. So there's two different types of compression, lossless or lossy. Lossless is exactly as it sounds. You're able to compress this image to a smaller file size, but without losing any of the image data. So you're not losing any of the detail that you originally received. So it can be reconstructed to be exactly the same as the original image. There's a bunch of different ways and different percentages that can be done, but the typical ratio for lossless is 3:1 for radiographic image management. For lossy, it's the opposite. So we can compress it down to a much smaller file size, but at what cost? We're losing some of the fine detail, which can lead to compression artifacts. So then we're losing that data, we're losing detail in the image. Therefore, we consider lossy compression to not be acceptable for archiving images, but for other data in general, perhaps it can be used, just not in our field. Object artifacts, you can get those from patient positioning, X-ray beam collimation, or histogram selection. Backscatter can also cause some issues depending on the sensitivity of the IR, like we talked about previously. An image histogram, if you've ever seen a histogram in math, it's just a graph of frequency versus the digital value intervals of whatever you're taking data from. So essentially, for each projection that you take, say a PA chest or a lateral chest, the computer knows what that image should look like based on the data that is provided to it. So it kind of stores all these image histograms over time, knowing that, okay, in that lung field, it's supposed to be dark. In the area where there's bone, there's supposed to be radiopacity. So it can average out what the pixel should look like for a specific image projection to produce the correct image quality. But say that you're taking a PA chest, but you accidentally set them up for a lateral chest, but you put in the computer that you're doing a PA chest. That image histogram is going to be off a little bit because it was expecting certain values for that data to be in different places. So that can cause some issues with the overall image quality itself as well. Similarly, if you don't collimate properly, then the histogram assumes that you're supposed to have certain data sets in certain areas, and those aren't there, so that image is overall a little bit more noisy. When you should shield, when patient shielding occurs, you can't have that shield within the collimation field, any of that lead shielding. Because of the beam interacts with the shield, and therefore you will be getting a small increase of patient dose from the scatter radiation. So it's essentially causing kind of a rebound of those electrons off of that shield and toward that patient possibly. So whenever you do shielding, make sure that it's outside of that field of image. And I've talked about partitioning in the past. Sometimes we'll see that with CR setups, especially with the smaller extremities. So sometimes you can do a 2-on-1 or a 3-on-1 where you're putting all of those images on one cassette and then uploading that into the computer and having it as one image. You can do that by using those lead strips to kind of partition your IR into halves or into thirds in order to not expose those areas to radiation. So that's all for the concepts. I'm going to show you some examples of artifacts that you may or may not see in practice. Some are much more common than others. Some are just for fun. So here on the left, we're looking at a lateral chest. You can tell there's a bunch of ribs here. Patient body habitus, so you can see a little bit of like the rolls in the soft tissue here. But most importantly, we're looking at this radiopaque density here. And so typically when we're looking at something like this, we're thinking, okay, is it a clothing artifact? Are they wearing something that has something metallic on it? Were they properly gowned in that way? Do they have something that maybe is embedded in them, a surgical artifact, or maybe a foreign object? In this case, this is a CR machine that took this image, and this is a bee that got stuck inside of the cassette. And so we don't get a ton into how the CR machines work, but a lot of the CR machines and how the film works has to do with phosphors and silver and having those little molecules activated. So this kind of, even though the bee isn't metallic and it's kind of showing up as radio opaque, it made it so that that part of the film couldn't be exposed to radiation, and therefore the silver and phosphor at that area couldn't be activated. So it made it look like it was metallic when it really wasn't. So that was just kind of cool. This is a really common one that you'll see. So we're looking at a lumbar spine x-ray. They kind of cut off part of the proximal lumbar spine, but that's okay. A lot of gas within the intestines here. That's what all the radiolucencies are, except for this kind of band-like radiolucency across the midline. You'll see this really, really often, especially in larger patients. This is typical of kind of that space in between fat folds. You'll see this kind of radiolucent banding, really common just patient artifacting that can occur. This can also occur if you're wearing really tight clothing and you're wearing it where it has an elastic band. So if somebody was wearing yoga pants or something like that and wearing them high, sometimes it'll cause kind of a pseudo like rolling effect there and cause that separation. So if you ever see that, that's what that is referring to. On the left here, so this is one of the x-rays that you'll actually be taking next semester that we'll be learning how to perform. This is an APOM or an odontoid view where we're looking at the upper cervical spine. And it's called APOM because it's A to P and OM stands for open mouth. So you can see their mouth is open, they have their teeth here, and we're looking at that C2 vertebral body. Great. So what is a pelvis doing here? So this is an example of a ghosting artifact. If you think about what could possibly be in the pelvis and be radiolucent in this kind of weird shape, this is a tampon and it is radiolucent because it has been used for a while, so you can tell that it's kind of saturated with blood. On this side, this is a lateral skull. Again, it's kind of cropped, but you can see all these kind of white polka dots. And this is, again, a CR machine where they had some issues with their phosphors and silver crystals becoming inactive. So this is just a really old cassette that needs to be retired because otherwise these look like either patient got shot and maybe there's a bunch of weird bullet fragments laying about. They're kind of small, but regardless. Or calcifications, something like that. But in this case, it was just an issue with the CR. All right. On the left, it almost looks like there's a capybara sitting in the patient's pelvis. You'll hear a radiologist a lot kind of making things up with things that they're seeing. But this is like the eye, the ear, the nose. Or you can see like a skull with like two eyes here, the nose. But what this really is a surgical mesh that was left inside the patient after surgery, which is obviously extremely concerning, can lead to infections, but this is what it could look like. On the right, you see like a clamp here, and then this kind of circular artifact overlying the iliac wing. In this case, this is a really good example of what a colostomy bag looks like, something that you may see a lot, especially in patients with GI disorders like Crohn's disease. All right. This is a much better lateral skull x-ray. We're actually getting all of the face, all of the skull in there, and we'll be doing these next semester as well. You can kind of see these horizontal lines coming across. which could mimic this sign that we look for in certain conditions, where it kind of looks like a copper, like a type of metal that's malleable. But in this case, this patient actually just has braids. So really dense hair can sometimes show up as radiodense, and you can see braids coming across the patient here. On the right, so all of these lovely little metallic artifacts sitting in the pelvic basin. Here on either side, we also have some stones. These are phlebolyths, really, really common, essentially blood clots in the mesenteric vessels. Not a huge deal. You may be thinking blood clots, but it's a really common variant that occurs in especially older patients, especially sedentary patients, but there's a lot of redundancy in the blood vessels down there, so it doesn't usually pose a problem. However, for this guy, we know this is a guy because this is a very common presentation. He has these radioactive beads implanted in his prostate. This is a really common therapy for prostate cancer. So this patient is receiving kind of active radiation therapy to their prostate with these embedded beads. You can kind of guess there's a lot of things that this patient cannot do because they're actively emitting radiation from their pelvis. So think no mall Santaing. Think also how close in contact they can come with other people. So when they have kind of this active radiation coming from them, what they have to kind of keep in mind. In the chest, here on the left, we have the mediastinum here, which is pretty normal. We're not catching all of the heart, but that's where the heart is, and the aorta is coming around here. Normal lung on this side, and then we have lung here, and then this big radio density with all of these little circles in it. So kind of a weird one, but it's a very classic presentation. And if you have somebody who's older, or you're working in a VA, or working on somebody that's pretty elderly, they may have had this procedure done. It's called the plombage. So if you're ever doing a chest and you see this kind of characteristic thing, and it's always in the upper lobes, it's where they used to do a treatment for tuberculosis about 50-ish years ago, where they inserted a bunch of foreign bodies into the lobe that collapsed. So things like ping pong balls, gauze. There's a pretty vast list of things that they would kind of put into that space. The kind of idea was to get rid of the space that tuberculosis could live, and to pack it with other materials. Although they did find out, well, that's not a great idea because putting foreign bodies in a patient leads them to get higher susceptibility to infection, and what is their lung capacity actually if we're taking all this space away. So they don't really do this anymore, but this is something that you could see on older patients who had had it done in the past. On the right, something that you'll see pretty commonly. So radiopathies that are bilateral, pretty standard for breast implants. Moving down, so big metallic thing with a bunch of wires sticking out of it on the left side of the chest. You may be thinking too that this is pretty peripheral, so it's pretty close to that subcutaneous tissue, although they're a little overexposed so we can't see it. So this patient has a pacemaker, so it's pretty standard. Radiologists will always look at the wires to make sure that they're in the correct place. On the right, again, we have a kind of partial lumbar spine. This is an iliac wing, and we have some vertebral bodies here. But all of these like little tiny radiopacities. So if we're thinking things that are dense, we think of things that are metal. Could this be scratches? Absolutely. This patient has a bunch of embedded acupuncture needles, either that they weren't taken out accidentally over time, or they're done for a specific procedure, I'm not sure. Things that this could also be, though, if you clothing artifacts could look similar to this, especially if they have like especially around this time of year, like a sweater that has like tinsel on it, stuff like that. So looking for those metallic clothing things that could be causing that as well. On the left, super common thing to see. This is a post-surgical artifact. So again, this is lumbar spine, but this is a lateral. So we're looking at all those nice square vertebral bodies. And anatomically, something that sits just anterior to those is the abdominal aorta. So it kind of looks like a Chinese finger trap, if you ever had one of those when you were a kid. But it's essentially a stent that goes in to maintain the shape of the abdominal aorta and its patency, so that those with aortic aneurysms, hopefully that they can maintain the shape and not have them dissect or burst. But you can see this is about what the shape of the aorta should be at this level, and this is the contour of the actual aorta. So they do have a pretty large aneurysm there. On the right, reasons why patients should be properly gowned and shielded. So patient is wearing jeans or something with a button and a zipper. So we always make sure that they're not wearing something like that, especially when we're taking a sacral x-ray. Turns out this patient's also wearing bedazzled underwear. So I have only seen this once when I've taken an x-ray. Usually patients are a little bit more conscientious of this when you ask them about anything that they could be wearing that has metal on it, although sometimes they just forget that they have that in. So that could happen. Unfortunately, you're not going to tell them to just take off all undergarments. We still want patients to be comfortable. So unless they specifically say that they're wearing something that could impact the nature of the study, typically we just go for whatever needs to be gowned at that level. This one's not a metallic artifact, but sometimes when you have printed things on clothing, you can also have those show up. This person just had decals of flowers, roses on their pants, so we kind of see those everywhere, and they're kind of impacting our ability to read, especially over the sacrum, where you have some bowel gas and things like that can kind of occlude that area in general already. Another reason patients should be properly gowned. So they're wearing a nice metallic belt. They're also wearing a shirt that says peace. This is just a post-procedural artifact. You can see this tube going into kind of their bowel area. On the right, those of you who are going to be doing any portables, especially in the ER, will definitely see these artifacts very often. So these little wire guys, they always look like blobfish to me. If you don't know what a blobfish is, look it up. It's pretty great. But this is like an upside down blobfish. This is its mouth, its eyes, and its nose. But these are pretty typical of EKG clips. So whenever anyone's in the ER, generally with shortness of breath or some kind of chest pain, they'll toss these on, so you'll generally see those as well when you're doing your AP portables. On the left, we have somebody who was actually shot. So all of those metallic fragments are from a shotgun, I believe. But similar things you can see with BBs, if those were to happen. But they're pretty focused in a general area and have spread out from there. On this patient, at first glance, you can't really see much. Like, they have a nice mediastinal shadow. Lungs look a little less radiolucent, but nothing really of note until we get right here. And if you compare side to side, it's a bit more radiopaque on this side. And as we go down toward that left side of the heart, we see this artifact. So we've seen a bunch of things that kind of have a similar shape that could be metallic surgical artifacts, things like that. But in this case, the patient actually has their hair down in a braid, and this is a hair tie. So whenever they have super long hair, super dense hair, or it's braided, it's most likely going to show up on the x-ray. So we always have them put it up as high as it'll go, so that it's not impacting our study, especially on a chest. This patient was asked to remove all metallic things from his person, although he apparently didn't want to take his vape out of his pocket. So that is sitting in either a breast pocket or like a pocket lower on his shirt. This, you may be thinking this is kind of a weird quality image. This is actually from a CT. It's a scout image. So it's sort of looks like an x-ray, just like lower quality. It can kind of help us localize where larger pathologies are. So if I'm looking at this and we're doing a head CT, I'm thinking, okay, that's weird. That looks like it could be a mass, but this patient also just had a ponytail, and this is their hair tie, kind of all encircled at the kind of crown of their skull. Something you might see in older patients, but is pretty uncommon, I would say. So some patients with erectile dysfunction will have these devices implanted, or sometimes external, to help them deal with that. So if you see this inferior to pelvis x-ray, or sometimes you'll see it even on a hip or a femoral x-ray, you can know what that device is.